if you're struggling and you really wonder why you keep doing things that don't work for you, for example, and you keep striking out in your romantic relationships and you keep picking somebody who turns out the worst choice, and then you do it again and you do it again. Those are patterns that it's good to try not to just keep suffering with.
Well, hello, everyone. Welcome back. This is going to be just such an outstanding hour. I am just so thrilled that we have one of really the most outstanding, distinguished legends in psychiatry. We have Dr. John Oldham with us. For those of you who aren't in mental health or psychiatry, let me just briefly share. Dr. John Oldham is currently the Distinguished Emeritus Professor of Psychiatry in the Menninger Department of Psychiatry and Behavioral Sciences at Baylor College of Medicine. Previous to this, he had the Barbara and Corbin J. Robertson Jr. Endowed Chair for Personality Disorders. He is also served and been the chief of staff of the Menninger Clinic. Earlier in his career, he was my boss. He was actually the very first boss I had as a psychiatrist way back in 2000 when he was back then he was, I think, the interim chairman, but he of the New York of the Department of Psychiatry at Columbia University, but he's also been the director of the New York State Psychiatric Institute, the chief medical officer of the New York State Office of Mental Health, which is one of the largest mental health systems in the world. And he's also been the Elizabeth K. Dollard Professor of Psychiatry and Law at Columbia University. He has been the president of the American Psychiatric Association, the American College of Psychiatrists. He has served and really been at the forefront of helping us understand character pathology, personality disorders. He's been involved in all of the versions of the DSM, and we could go on and on. Dr. John Oldham, I think, also importantly, is a psychiatrist, a psychoanalyst, and just a gifted clinician that all of us look to as we're trying to understand the complexity of ourselves and our patients. Dr. Oldham, it's such a treat to see you. Thank you so much for joining us.
Drew, it's a pleasure to be here and a pleasure to reconnect with you after quite a few years.
It's been a little while. Well, Dr. Oldham, can you start, please? Just tell us what is a personality disorder?
Well, let me just chat a little bit about that. Personality itself is something we all have. When I'm talking with families, and I'm starting very general here, I sometimes use a blood pressure model. Every human being, to be human, has blood pressure. Too much or maybe too little of an essential ingredient of being human can be a problem. You can think of that as a template of how to think about personality. Each of us has a personality, but that personality is unique. It's kind of like a behavioral fingerprint, so that each person, no two people would be identical in terms of a personality. And personality itself is really the essentials of a person's personality. I would refer to, in the language of what's now called the alternative DSM-5 model for personality disorders. And we can get into that in a little more detail. But the essence of it, and the reason I bring it up now, it helps you understand what we mean when we're talking about personality. And a normal, healthy personality, using that template, would be someone who has a solid, clear identity. He knows or she knows who you are, and also you're able to guide your life in a meaningful direction. You can set goals for yourself and then move in those directions and reroute yourself if there's a need to. So you can direct yourself and you know who you are. And the second major ingredient of a healthy personality is a capacity to have healthy interpersonal relationships. And that's usually unpacked into two things. One is a capacity for empathy. You're able to put yourself in somebody else's shoes and see the world through that person's eyes. And then your capacity for intimacy. And that's not meant in a romantic sense, it's meant in the capacity to have mutually rewarding, lasting friendships and relationships over time. So, do I know who I am? Can I understand other people? Do I really have good and close friends? And can I direct myself and my life in a meaningful and hopefully rewarding way?
Now, everyone listening is probably thinking a little bit around these aspects of our lives. And if probably we're in a good spot, feeling maybe connected up, we don't maybe not struggling with maybe something like a little depression or just some of the anxiety of the modern world is getting to us. Maybe we're not struggling in those areas, but I think a lot of us sometimes we do. I just turned 50, as I told you. Boy, I have I think a good sense of myself, but you start to question it. I think, John, how do we know or have some sense, if we're struggling in these areas, how much of a, I guess, personality disorder do we have? Like, how do we take our blood pressure?
Yeah. Well, you begin to look, and there are many ways to do this. There are lots. The world is filled with researchers and smart things that people have written. There's something called the Big Five, which is the sort of psychology world, looking at major traits that sort of personality is made up of. But I'm more used to the model that we now have in our medical field and in psychiatry, and that's this model that I just described. If there starts to be impairment in functioning in those areas, and particularly if at least two of them aren't working very well or never got off the ground, then it's impairment in functioning that is going to be the shorthand to try to identify if there's personality pathology that might rise to the level of being a personality disorder we would diagnose in the consulting room.
Mm. So really looking into the functioning within my interpersonal relationships, our sense of self and our ability to kind of see and achieve goals. When we have like problems with these, what do we like? What do we do? Is there? I think so often with character disorder, personality disorders, there's this idea. Wow, that's it. That's your personality. Like it's kind of permanent. Are there ways that we shift and shape our personality and treatments for these?
Yeah, sure. People have all been spooked about personality out there in the world, and that has happened forever, and it still happens. People are afraid to have somebody look too deeply at who you are, and sometimes you don't want to take a personality test because it might reveal something that you'd be ashamed of. So there's a fear and anxiety around it. So that's true just in personality in general, and certainly if you have a disorder that might be a diagnosed disorder, that's something that people don't feel don't welcome, and that would be true for lots of forms of major mental illness, such as depression or an anxiety disorder.
Yeah, but I'd rather get, if I came to see you and I was a little, I don't know, panicky or anxious or struggling with empathy, I'd rather you diagnose me with panic disorder and than I would if you diagnosed me with something like a narcissistic personality disorder. That sounds kind of scary.
Well, right, but you're in the field. You know those words.
I can handle it. Okay, John, I'm ready. I'm ready. Tell me.
um, that's a common reaction, and for some reason, or in part, there's a legitimacy to it because personality disorders are not necessarily going to be amenable to easy change. You can't, for example, take a pill and after 4 to 6 weeks be at a better place because medication is not a useful treatment for personality disorders. Let's use an example of borderline personality disorder.
Could you just share for everyone listening, because as you noted, there's so much sensationalism. Sometimes we think about borderline personality disorder as maybe like cutting or like, a provocative, behavior. What is borderline personality disorder in your words?
Well, borderline personality disorder, it's a funny term. Borderline itself doesn't sound like it makes any sense. And it was originally coined because the original notion was that there were patients who had a lot of emotion dysregulation, a lot of just tumult in their lives, and who at first were thought to have something like a major mood disorder. But then they behaved, and sometimes under stress, in such irrational ways that the original notion was that these were patients who were on the border of a major mood disorder or a neurotic condition, to use an original term, or on the other end, a psychosis. So it was thought to be in the border between having a neurosis or having a psychosis. Well, that doesn't turn out to be what borderline really is. Borderline, though, is still, and when I've talked to families, I think you can still use the term because it's on the border of being a major mood disorder or a major impulse control disorder. And those are two categories of disorders in the diagnostic manual. So it's somebody who doesn't, in fact, have a very well-formed, coherent sense of identity, who doesn't really know, I don't really know who I am, and the world is baffling to me. I don't understand other people. I get moody. I have a lot of trouble trusting people. My emotions go off like a shot at the least provocation, and sometimes I just imagine things and then get so upset that I can't just go about my daily business. Instead, I just get agitated and upset, push everybody away, and sometimes will even harm myself, such as cut myself or injure myself in some ways, which you'd think would be making things worse. But for these patients, it sort of provides some kind of release and enables them to sort of calm down a little bit. So a borderline person is somebody who hasn't been able to get beyond sort of the early phase of development and is kind of stuck and hasn't been able to mature in a comfortable way. Frequently, there have been pretty stressful things in the lives early on of people who develop these conditions, but not always. More often than not, there will be a history of some pretty traumatic early life experiences, and that contributes to it. But there's also a heritable risk to develop this condition, just like there is to develop other personality disorders, just like there is for depression, bipolar disorder, other major illnesses. So it's really somebody who has difficulty understanding other people, difficulty trusting other people, and that relates back sometimes to having bad luck and not having grown up in an environment where people were trustworthy. And sometimes, therefore, the need we all have to have a mature, caring, loving adult model in our early lives to teach us and guide us what trust is all about hasn't been part of this person's life. So it means that you get to a sort of anxiety-ridden, bewildering effort to navigate in the world when you don't understand yourself, you don't understand other people. Sometimes what you'll do is see somebody you admire and start to copy that person and behave like that person. And maybe that's how I should be. And so you sort of borrow somebody else's identity. But the trouble there is that then you sort of attach so closely and that person becomes so important to you and you're so needy that you sort of smother and suffocate the other person. And it ends up intolerable. The other person will say, this is more than I can handle. And then it's like a self-fulfilling prophecy because then I knew I couldn't trust people. I thought I could trust you. Once again, just like I thought, you can't trust anybody in the world. And I could go on, but these are some of the major challenges that these people have. Now, it's important to add that this is a treatable condition. I chaired the American Psychiatric Association work group that developed an evidence-based practice guideline for the treatment of patients with borderline personality disorder. And the first edition of that actually was published in the American Journal of Psychiatry in 2001, so a while back. And
right, we met.
right then, that's right. And there's a new edition that is going to be posted on the APA website this month. And so it's been a long time, but we've had a new work group that's been working on this for the last few years, and I've been part of that. And so there will be a new version of the treatment guideline. The point about it is that there are quite a few evidence-based types of psychotherapy that have been demonstrated using rigorous randomized controlled trials that are effective in helping people with this disorder. And the primary and core treatment for borderline personality disorder is psychotherapy. And preferably one of these studied and established types of treatment, such as dialectical behavior therapy or DBT, mentalization-based therapy or MBT, schema-focused therapy is a third one. A fourth one is called transference-focused psychotherapy. The Kernberg group at Cornell have developed that, and there's a lot of research that's been published. And I could go on. There's a group approach called STEPS that the Iowa group have developed. Finally, there's one that's called general psychiatric or good psychiatric management, which the late John Gunderson and the McLean group at Harvard developed. And all of these have been tried and demonstrated to be effective. There's no quick fix. It's not going to happen overnight. It's not going to happen even in a few months. Usually there needs to be a process of therapy over time. And if you look at a prioritization of what the goals are of the treating psychiatrist, treating someone with borderline, the first one is to keep the person alive, because there is an elevated risk of suicide in patients with this condition. And the second goal is to keep the person in treatment, because these patients have trouble trusting other people. And that means they also have trouble trusting you if you are their therapist. So these patients will fire their friends when they get too anxious, and they'll fire their therapist when they shouldn't. And so one of the challenges of any of these forms of therapy is to be aware of that, and then to help the person navigate while staying in the treatment relationship.
John, when you're talking about the length of treatment for people who have borderline character disorder, but also maybe thinking about how we shift our personality or character structure if we're struggling in some of these areas. Personalities, it's something we all have. So maybe we do a great job at work and we achieve lots of goals, but we really struggle interpersonally with intimacy. Sometimes I think about it as almost like a little chasm in my character, where I'm functioning pretty well, but there's this one thing, and boy, I don't do a very good job with it. Can you tell us a little bit about how long it takes to shift character, both in examples you were giving of people with borderline character disorder in a structured treatment, but also for all of us who maybe, have a little quirks that we're wanting to work out or fix about ourselves?
Sure. Well, as I said, for somebody with clear and disabling borderline personality disorder, ideally, you enter treatment with someone and develop a comfortable relationship. It can still be stormy at times, but you need to continue in that treatment. And the likelihood of really getting a best benefit from treatment is to stick with it probably over several years. Once a week, 2 times a week. 2 times a week is a lot, and People often can't afford it. It's not also accessible. It's not available. The person you might need to see is not in your particular accessible area. These days, with virtual treatment, subsequent to the pandemic, that's become much more common. And so there is access to treatment a great deal more because you can, in fact, have quite effective work done virtually by telepsychiatry. So it'll take some time. Now, that doesn't mean that it's black and white, all or nothing. It's a gradation. So let me say a word about that. In our medical system and in our diagnostic system, we think categorically. You either have this illness or you don't. You have pneumonia, or you have cancer, or you have heart disease, or you have depression, or you have bipolar disorder, or you have a personality disorder. So the personality disorders have been diagnosed in the same categorical way, a list of presumably different from each other conditions. So narcissistic personality disorder is on the list. Borderline is on the list. Antisocial is on the list. Avoidant is on the list. And so it goes. And each of these disorders is then defined by a set of defining criteria. Now, for years and years, the field pretty consistently has recognized that this is not a very useful way to think about personality pathology or personality itself. In fact, it's a categorical way of thinking that doesn't quite fit. And a far better way to think about it is dimensionally. Now, an easy way to think about the difference between the two is good examples of a dimensional concept are height and weight. There's no break on the spectrum. It's from lowest to highest, and you can find somebody at every point in between. Whereas categorical examples are being male or female or being a pregnant woman. These are clearly unique conditions, and they're different from each other. That's the system we've used. We're somewhat artificially acting like each of these labeled disorders is different from the other one. But it never really comes out that way because personality is far more likely to be dimensional.
It's never felt that way in clinical practice. Also, occasionally you see a patient and it's really clear that the criteria fit them perfectly. This is like a really sort of say classic presentation, but so often there's that mix. I think we see that often in mood disorders as we've expanded our thinking, and certainly with all of my patients in therapy, there's a way that you sit with someone who feels like maybe they lack empathy and are narcissistic, and they come in one day and you're blown away by this amount of empathy they have for a specific thing. So, or they're behaving like it feels like a very different type of character style.
Yeah, and that's very much more common. And actually, the DSM-5, when it was first being thought about, the marching orders for everybody were to try to move in a dimensional direction, because it's true for depression too. There's not one size fits all of depression. There's major depression, there's minor depression, there's dysthymia. These are different versions over time. So we use medical language that helps us communicate with each other. And as long as we understand that that's kind of a convention, but it's not really something that is hard and fast and black and white. Let me just illustrate it one other way. Years ago, when I was earlier in my career, when DSM-3 was developed, that was when we had the first sort of list of the personality disorders and criteria to define them. And I was interested in personality from early in my career. One of my supervisors was Otto Kernberg, who has developed transference focus psychotherapy. And after I finished my residency and worked at Columbia for a few years. Then I went and was on the faculty at Cornell and worked with Otto and, in fact, with John Clark, and co-led the first ever research project on borderline personality disorder in the Kernberg group. So I became very aware at how sort of unwelcome the whole discussions about personality were out there in the world, that people didn't want to be labeled with any of these labels because they felt that it was a bad mark, and also felt that it reflected family pathology and weakness, and so I don't want to have one of those labels. So I had the good fortune to meet a medical writer, a journalist named Lois Morris, and together I said, let's write a book for the public that will help them get comfortable with thinking about personality and not be spooked by it and scared off. And so it took a long time, but we did. We wrote this book that was called The Personality Self-Portrait. Now, one of the things that I did at Cornell, collaborating with a wonderful psychologist, a researcher named Armand Loringer, was to develop a personality disorders examination, which was a semi-structured medical evaluation to systematically evaluate the personality disorders of DSM-3. And that's actually one of the semi-structured interviews that was very well thought of and validated and widely used. And there's an international version that's actually still used in a number of countries throughout the world. I based the book we were writing on a self-assessment test that was derived from the bones of that semi-structured interview. The interview was to evaluate pathology. The test that I developed was to evaluate styles of personality, not pathology. So, for example, what I did was look at the criteria for each of the listed disorders and conceptually sort of turned the volume down until it became a healthy, useful style rather than a pathological condition. So take narcissistic personality disorder. That's a term we're all pretty familiar with these days and is very commonly thrown around in the world. Well, it's actually a big problem, and in fact, it's one that's a little harder to treat than borderline personality disorder because people who have this don't acknowledge that they have it. Part of the pathology is that I'm the greatest person in the world, and there's nothing wrong with me, and I don't need help. Go away.
And if I did need help, no one's qualified to help me.
That's right, because I know more than anybody else. So they don't get into treatment very much. So I'm the greatest person in the world. I'm somebody that people admire and they should admire and want to be around. I'm very important. And if your needs aren't met because you're a colleague of mine, well, you're just lucky to be able to be in the same room with me. So just deal with it. So there's a lack of empathy, there's a lack of sensitivity, and there's a grandiosity. So turn that volume down. And the style we describe in the book is called the self-confident style. Well, that's a good style to have. And if you have a reasonable amount, even a large amount of self-confidence, you can go a long way in life. So if you have that style, then that can be a benefit to you. So for each of the listed pathological conditions, we turn the volume down to a non-pathological adaptive style. What's assumed or implied in what I'm talking about is that goes back to what I said a minute ago about having a particular unique fingerprint. Nobody has just one style. everybody has a combination of styles, and some will be more prominent than others. So what we did was we developed this test, and then it's in the book, so you can take the test and hand score it in the book and look at how high or not, how prominently or not your personality consists of any one of these 14 different styles. And so that actually turned out to be, we were successful and more than we ever dreamed. That book was published in 1990. The second edition was published in 1995, and it has been continuously in print until today, and it's still available new on Amazon. Now, I'm not saying that to toot my own horn. I'm saying it to say that we struck a nerve. We were successful in our goal, which was to help detoxify the whole idea of personality pathology and help people get interested in their own personality. So one other piece of that project, since I've been here in Houston and was on the faculty at Baylor and was at Menninger Clinic, there are a lot of great colleagues, and one of them very smart clinical psychologist named Alok Madan. And Lois and I teamed up with him, and he helped us develop a version of the test that was updated and we posted online. So with no marketing, we just put the test online to see if anybody would take it. Within the next few years, over 12,000 people worldwide took the test, to our amazement.
Wow. And this is a test. Can we kind of get a sense of our personality self-portrait taking the test?
Yes, indeed. Yes, indeed. And so that was so amazing that we then made a major upgrade of the website. And the website is called npsp25.com. And that stands for the New Personality Self-Portrait. And 25 was when we were doing this. It was at the 25th anniversary year, about. And we just kept that title. But what you do then is that you can take the test online. It will show you your own personality profile, and then a whole raft of information kind of describing the various components of your personality profile. But it also shows you how you compare to the average result of 12,000 people worldwide.
Kind of see, like, in these various parameters for my personality, kind of where I rank.
Yeah, that's right. So, for example, if you look, I've got a slide set where I showed a series of these results. The results are anonymous, and so people don't have to worry about being revealed or exposed. But if we look at the pattern or the profile, and I just, on some of these exercises, I pick self-confident as one example. And so you look and see, to what degree are you self-confident? And how do you measure up compared to 12,000 people in the world? And you are at what percentile? So you are at the 12th percentile of others in the world. That means you might want to think about that. You might want to.
Well, I'm guessing they're also, given your long clinical experience, maybe some recommendations or ideas of, for example, if you are in the 12th percentile of confidence, things that we can do or ways that people enhance their confidence.
Absolutely. And the book is full of what we've called tips on making the most of your particular style, as well as tips on helping others understand others. And one of the other things you can do, which is really cool, if you look at the website and click on the About Us tab, that will just show a little bio of me and Lois and Alok, but it also shows each of our personality profile results. And then at the bottom, it superimposes all three so that you can see with different colors. So you can see if I'm really high on the dramatic style, but Alok is not at all that high. That's very interesting. We're different, but we balance out, or we don't. And so couples can compare themselves in a very interesting exercise.
Well, sounds like this is like a fun date night. Take the personality disorder personality self-portrait, not disorder. Don, I love that your own personality profile and self-portrait are up on your website. And I'm curious, how do you, as a psychoanalyst and psychiatrist, think about your own personality? How do you get bogged down in the kind of, I don't know, call it neurotic thinking that mental health clinicians sometimes can have, where we wonder about ourselves, and there's so much clinical content and emotional stuff that we're processing. So, can you tell us a little bit about how you reflect on your own personality?
Well, sure. For one thing, I got to know myself pretty well by 5 years of psychoanalysis. So, as part of being a psychoanalytic training requirement at Columbia and all other psychoanalytic training centers, you agree to enter a personal psychoanalysis and experience the process yourself. And I say that because it did help me understand myself profoundly more than I think I could have otherwise. If you're in treatment, that's another way you work on understanding yourself. So getting help is going to be one of the bottom lines of our conversation today. That is important for people not to be skittish or hesitant to get help, even if you're not sure you really need it, but go check it out. So I took the test myself, which was a little unfair because I wrote it. So I could cheat, but the guideline to everybody who takes the test is just try to be quick, answer the first thing that comes to your mind. Don't overthink it, and just try to be as honest as you can. Our behavioral health world is filled with all kinds of standardized assessments. But in essence, they're all self-tests because they're correct or not, depending upon whether you're telling the truth and answering honestly or not. So you just do your best. I have one little extra advantage here, and that is that I actually have an identical twin brother. And so I had him take the test, and we put our test together, and it made sense. He was much higher. He was much higher on the aggressive style.
Have you guys been having this argument your whole lives that he's the more aggressive twin?
He was the dominant twin, and they're not always that way, but sometimes there is. And I was much more reserved than he, and it showed up right away in the test.
John, you said something about your own psychoanalysis that I think maybe a lot of us maybe struggle to understand, or people outside of the field. The idea that you, at this point, you're a physician, a psychiatrist, accomplished, self-aware, published, probably knowing you. The idea that at that point in your life, you go in and you learn something deeply about yourself. I think also, especially as you're a twin, so it's not like you hadn't thought about yourself in maybe particularly deep or nuanced ways. It speaks to something I don't know, very intriguing to me, that all of us, or most of us, could use some type of help with the type of I guess awareness or insight. I was wondering if you could share a little bit of that process. Like, what do you see happens either to yourself in your analysis or with your patients?
Sure. Well, I wouldn't say that it's unique to psychoanalysis, and psychoanalysis is certainly not for everybody. It's very expensive, and a very intense and time-consuming treatment. It was part of the requirement. I don't know that I would have been able to or could have afforded doing it if it weren't part of my training that I was involved in. But there are steps along that road that are important and really helpful. It goes back to what I was saying a minute ago, which is if you're struggling and you really wonder why you keep doing things that don't work for you, for example, and you keep striking out in your romantic relationships, and you keep picking somebody who turns out to be the worst choice, and then you do it again and you do it again. Those are patterns that it's good to try not to just keep suffering with, but
there's a reason, there's a kind of method to it. There's a reason for these patterns.
Right. And we're not the best judge of ourselves. There are things that are embedded that developed as we were young and growing up, things we were taught, ways that we were taught to believe that we sometimes later find don't work for us very well, or we really don't understand why we behave the way we do. And so getting help with somebody who's a therapist and can help you sort through and think about it can be very beneficial, and you can change. And just like personality disorders can get better with treatment that's adequately long and in depth, you can get even a lot of benefit from, for example, a 6-week, once a week course of cognitive behavior therapy that's structured around a particular concern that you're worried about, such as the one I just mentioned. Why can't I pick somebody good?
I love the idea that psychotherapy, that we kind of come from this tradition of psychoanalysis, be on the couch 5 times a week, and that isn't so accessible or practical for many people. And it feels to me, as someone who loves that work, I'm not a psychoanalyst, but psychodynamic psychotherapy, it just feels like it keeps I don't know how to put it. It feels like the thing that's been truest in my life thus far. Like to recurrently get a glimpse of the grand unconscious, to recurrently see concepts like transference and character and the patterns of people's lives playing out. It's been refreshingly true.
Let me give you one little example, because you mentioned the word unconscious. And we know that there are things that motivate us that we don't have awareness of, but we still behave in certain ways that are driven by experiences we've had, or impulses that we don't understand, but that we keep behaving, acting on an impulse. And sometimes memory itself is inaccurate. We sometimes don't really remember things accurately. So this is a sort of simple little example. But when I was a boy, I had an experience that later during my psychoanalysis came back to me. I remember, and I was telling my analyst about it. And I was about 8 or 10 years old, and we went to a neighbor's yard in the backyard for a cookout. And they had a great big fish pond that was not a little one, it was pretty big. And my twin brother fell in the fish pond. But it turned out that when I remembered it, I remembered that I fell in the fish pond. And I could visualize it. The water was closing over my head. I was in a panic and terrified. And I would have sworn that was the real story. My mother was visiting that shortly around that time, and I told her that I remembered this, and she just looked at me and she said, You didn't fall in the fish pond. Your brother did. And the weird thing was, he jumped right out and was fine. You went to pieces. Now, isn't that interesting?
How do you understand how when our memory works that way, do we sort out the truth of things for ourselves?
Well, that's the challenge. That's the challenge. But the message is that things are not always how they seem. And that can be kind of scary, but at the same time, it's something to be curious about. In this case, I was so closely identified with my brother that I was terrified for him and translated it unconsciously into my own experience in a way to relieve him of danger. Um, but he didn't have the same experience that I did. So that's a sort of specialized kind of relationship. But there are many times where we can have um, things that we think are really valid, but they may not be quite accurate. And thinking it through can help sort things out. I'm not talking about recovered memory syndrome or things like that, because I think that there's a lot of hype around what people might need to uncover from their unconscious that they don't know, because I think that's exaggerated and way off the charts.
I am not so much what you kind of lived through and were a prominent psychiatrist during the era of recovered memory syndrome, which is a specific kind of piece of mental health history. The notion that things are hidden in our conscious has a huge resurgence right now, and it's also really fueled by the psychedelic movement. The
Mm-hmm.
notion that symptoms, physical symptoms, mental health symptoms, kind of all have a root in trauma, and that can be recovered through psychedelic medicine in some ways is a very prominent theme I hear, and it's had me a little concerned recently. Almost the idea that what we begin to understand about how people can be indoctrinated into a set of thinking. And as you note, if our what we remember and are encouraged to remember can really have profound impacts on our mental
Yes,
health. And I
yes.
wonder what kind of how you see this.
It's a slippery slope, Drew, and I think that it's interesting to see the resurgence of interest in a controlled way in some of these psychedelic compounds. And, you know, we need to control it, but also carefully evaluate whether this is something that, under the right set of sort of parameters, could be very helpful. And that's very different from taking street drugs back in the hippie days, which was totally uncontrolled. And sort of we got kind of allergic to these compounds and stayed away from them for decades. And I think going back there and looking at them, and sort of ketamine helped us get into that. And then psilocybin is now a very clear area of interest. And it may be that these are chemicals that then the body is full of chemicals. That's what we're made of. And so there may be ways in which um, a, a, a conscious experience prompted by the right amount of some of these chemicals, some of these compounds, can help us unlock things that we had put a heavy lock on and put on the shelf in a box, and then get to a comfort zone where you can sort of release and move away from being scared of trying to understand things that may have been very difficult or scary to you in the past. So I guess what I'm saying is I think we don't have the answers yet. We're still in the middle of a renewed interest in these compounds. But if somebody is suffering terribly from a really profound depression and is at a point of being suicidal or thinking about it, And there's a way to help the person turn that into an optimistic search for hope. And if these compounds are adjunctive and helpful, that's important. But I would say, as a psychoanalyst, that to whatever degree these compounds may be helpful to some people, almost for sure it should be done in the context of an ongoing therapy relationship with a therapist to help you work through what you're experiencing and then continue to understand in an ongoing interactive way with a skilled therapist.
Yeah, all of the protocols that seem to be working well, for the most part, are psychotherapy protocols. 16 to 20 hours of preparation and integration work around these compounds. I find in the real world, it's sometimes a little challenging to have that happen as well or as accurately or as, let's say, diversely as you would like. That really good integration involves things that we tend not to do too much in mental health, shaking, dancing, drawing collages. But I really appreciate that, John. I think that the notion of kind of control is, you mentioned supply, which is when we had Julie Holland on, and it was interesting to hear her as a leader of, one of the leaders around psychedelics, kind of say she wouldn't, take anything that she found out in the world, in the street, that this just supply is completely contaminated. Um, However, we also know that there's a lot going on out there in the underground world that isn't being led by mental health, and in some ways feels a little like in opposition to mental health. That there's a way that what you and I maybe think of as creating strong alliances feels to people like dependency, or how maybe you and I might think about how we deal with memories or things that are locked up that come out during a journey, how to maybe check on some of the veracity of that. So you noted even your fine mind had a major event that was seen through, in some ways, a lens. This falling, your brother fell in, but you thought it was you, which also maybe, as you allude to, maybe makes sense in the dynamics of the twinship that you shared a little bit about.
Yeah. Well, and it's important to add that the internet is the Wild West. And so there are lots of things that people can access in the internet that aren't necessarily going to be helpful and that aren't, in fact, built on solid principles and that are provided by people who aren't adequately trained and credentialed. And so that's very important for people to be cautious about and to look for help, but look for help by well recognized experts who have authentic credentials and are well trained.
Well, I think that's the question so many people have. How do I find someone to help me with this? And I really appreciate the self-portrait, self-test, maybe to give us a little more specificity. I think a lot of times people feel so intimidated by mental health because they're not sure exactly what to ask for. A lot of times in evaluations, I kind of say to people, let's get specific about the work order here. What it sounds like, let's see, there's a kind of a set of work around, a family relationship, repairing something with a sibling, or there's a set of issues around this, but really trying to get clear with ourselves, maybe what parts of our character and our personality we want to work on.
And the other thing I would add, which goes back to something that you're very involved with, which is we know now a whole lot more than we used to about the really inseparable relationship of the mind and the body. And so what's so important is to take care of your mental health while you're taking care of your physical health. And that goes importantly in terms of nutrition and exercise and behaving in a way that is strengthening overall your entire sense of self, which includes your physical health as well.
Mm. John, you are a distinguished professor emeritus, which I think, as you shared, means you're in your 80s. And as an octogenarian, you seem sharp as a tack to me. I've walked around annual meetings with you. You are full of energy, full of creativity. You are having these chapters of your life in a way that we all hope to. And I'm wondering if there are some things in your journey that have helped you stay sharp, stay optimistic, stay productive. really stick out to you?
Well, first of all, thank you for saying that. One's cognitive capacity has been fairly much in the news these days for people in their 80s or late 70s. I won't say more than that. But I do feel that I've been fortunate, but I've been careful. And in my sort of lifetime habits, I'm not a heavy drinker. I watch my diet. My wife is someone who makes the Mediterranean diet, and that's our gospel in our house. And I've been a sort of exercise nut. I've been a runner all my life. I ran 3 New York marathons earlier in my life. And so part of my standard habit list includes trying to be careful about my physical exercise and diet, and those are things that a lot of people are not as attentive to, and that's going to be it's going to backfire, or it certainly could.
Is there certain things that, as an analyst, you have as a set of motivations? Like sometimes when I don't feel, how do I put it? Like when I'm not making the right choices, I'm not exercising, I'm eating all the ice cream. I almost feel like this, I feel horrible as a psychodynamic person. It must be this like self-destructive thing inside of me. Like, I know better. I like to exercise. I'm an athletic person. How have you stayed so motivated?
Well, I mean, figure out how to trick yourself. Sometimes that helps. So, for example, in all of my years of regular running as my exercise, the great development was the development of skilled actors who read audiobooks. And so I find a great murder mystery, I rent it, and I listen to it when I run. And I don't let myself listen to it anytime except when I run. So if I'm at a great place in the book and it's time for my next time to go out and I don't really feel like it, it helps me get out on the road, because
you're not going to know who done it, right? You're not going to know. It's like such a slow dopamine burn, right?
Yeah, that's a silly example, but not really.
It's a great example.
You just figure a way to make it worth it to you.
You mentioned diet and you mentioned your wife's Mediterranean style cooking, which we should definitely give a shout out to her. I'm wondering if there are certain foods on this Mediterranean diet that are go-tos for you that have been, a part of you thinking about your physical health and mental health.
Well, look, my daughter is vegetarian. My son is sort of a pescatarian, or whatever the term is. He'll eat seafood, but
healthiest. Your son's the healthiest. What a good boy.
Health conscious, right? And I've sort of moved steadily in that direction. Look, I grew up in West Texas, where the nutrition was steak, and if you had anything called seafood, it would be frozen fish sticks. That would be it. And so I've emerged and evolved a lot over time. And now I'm at a point where I don't eat much meat at all. I'm not claiming to be a vegetarian, but I just prefer kind of Mediterranean diet that's got a lot of pasta and olive oil, and we don't have any butter that we use in the house, and just my wife's got an Italian background, and that comes naturally to her. And so you can change your habits, not all at once, but you can gradually transform from maybe a early life where the thing to do is to go get another Big Mac and move away from it. And sometimes it requires conscious effort to do it, but once you get in the habit, it becomes second nature.
Yeah, that's been such a striking thing for in my life, of that kind of how much getting into the habit of things matters. It happened with alcohol, which I gave up a few years ago, and it's just so striking to go from sort of being in a habit of having alcohol with a lot of your meals, to just sort of nod, and how the brain really shifts over months and years. And it's just a really
Yeah, you
developing
think
these
you think you need it, and then once you get past that, you realize you didn't really.
Yeah, my hope of a new book, Healing the Modern Brain, and the hope is really to try and create a set of mental fitness habits for people. So
That's a
instead
book.
of saying
That's the book you're writing now.
yeah, I just turned it in yesterday, actually, John. It's really
Oh,
special to have you on the calendar this week, a kind of a milestone, or a nice marker looking back in terms of this arc of knowing you for really my entire career. But the notion of, can we help really as mental health professionals, as psychiatrists, really see this is the stuff that's working. As you're saying, there's not a mystery, there's not a question in the science. Every authority you talk to, moving your body more is good for you.
well, good for you, and I know you've written other things as well, and I'll look forward to seeing the new book, because I think your focus is a really important one, and I think it's not widely endorsed out there in the world as much as it's so important in terms of overall health, which is part of what keeps your mental health in a good place.
Well, thank you, John. It means so much hearing that from you. I think for so long in our field, and I get in this stance, I feel protective. I feel like people saying, kale's going to help with mental health. It's like, now hang on, this person really needs evidence-based solutions. And so it's been really fun over the last 15 years to see the Mediterranean diet really rack up some points in terms of good data that it's helpful. And I love that the trials are augmentation trials generally, although the most recent trial of a lifestyle intervention, it was nutrition and sleep hygiene, I believe, were the two pieces delivered by telepsychiatry, was shown to be equal to cognitive behavioral therapy for the treatment of depression. So, there's a lot of interesting stuff going on. Um, I have a weird question for you about what happens as we age, and I have a really acute example. As I've gotten a little bit older, I noticed these moments that happen. Things kind of seem to line up, like I'm in the right place at the right time. And I remember I've heard sort of Jung spoke about this, and really curious with all of your experience with Otto Kernberg. I feel like we're directly tapped into the lineage of psychoanalysis here. But I'm wondering what these moments mean. And the one that I just had, in 2001, I was a PGY2 resident. And so for everybody listening, that means in psychiatry, you're going to get your very first long-term psychotherapy patient, someone who you're going to see once or twice a week for the next couple of years. And for some of us, we were lucky, and those patients continued with us, some for many years. My very, very first long-term psychotherapy patient, I realized I saw in Ariel Stanford's office, who's now a prominent psychiatrist herself. And you were our chairman then, sitting up on the sixth floor PI. And it was very strange to me, because just before I spoke with you, this patient has come back to see me for a kind of acute issue. And I was just speaking to her. And it's just hard not to see that as something, and I don't want to get like overly emotional, but I'm wondering, when that happens to you in your life, when you see that happens to people, things kind of line up. What does that mean to you?
I don't know the answer to that, Drew, but I do know that it does happen. I've had experiences like that that are just weird, and you think, how could this be the case? I mean, I went to an international meeting in Australia and sat at a dinner table with all these people, some of whom I knew, some of whom I didn't. And a woman across from me was a clinical psychologist trainee. And just we happened to be chatting. And she told me she was in training in a school in New York. And anyway, long story short, one of her most admired teachers was my wife's best friend, who has been her friend since high school. Now, what are the odds? That's not a momentous event, but these are the things that happen that are really remarkable. And the other thing that I was reminded of as you were asking that question, luck has a lot to do with things. Things come along that we wouldn't necessarily expect. I'll give you one example. I was at Columbia in my training years, and then later on the faculty. And then after being at Cornell, went back to Columbia, and that's when you and I later met. And I was really focused on psychodynamic thinking and got into psychoanalytic training. And along the way, since the Psychiatric Institute in New York is a state research facility, the importance of support from the New York State Office of Mental Health, the state agency that ran all of the state hospitals, they supported us, and we got our budget from them, so we had to be very interactive with them. Long story short, New York appointed its first ever non-MD commissioner of mental health. So they needed to create a job called chief medical officer. And the commissioner asked me if I would assume that role in a transient sort of interim level while they did a search for someone else to have the job as a permanent job. Well, I was in psychoanalytic mindset and not somebody who would see as a life goal being interested in very disabled patients kept in state hospitals. But this was an opportunity. And so I said, sure, I would try to help. And it turned out that then I ended up being chief medical officer for about 12 years while doing lots of other things. But I learned an enormous amount about the suffering of very disabled patients with serious illnesses that I wouldn't have aimed toward as my own choice. So the thing is, be open to new opportunities that come along. As an example of that, I gave grand rounds at Baylor on Wednesday, 2 days ago. And what was that? That was 9/11. That was the 23rd anniversary of the 9/11 attacks. And I showed a slide that said we need to pause for a minute and just remember. And then I showed a slide of me with some other state officials with hard hats on ground zero, about 3 days after 9/11, when the smoke was still quite visible. And that was something I would never have thought would have been part of my life experience. But it's a momentous one that I'll never forget. Point being that even if it's not something you would have necessarily thought would be high on your priority list or your choosing list, think it through. And there may be ways in which you could really go down a road that opens up to you, that can be very rewarding, that you might not have really looked for.
Yeah, you kind of call it luck a little bit. I think that makes it, and that's made it hard for me, as like a parent and the idea that it's it's luck and I should be prepared for it. But I really love the way it seems that you bring curiosity and openness, as you say, as a psychoanalyst thinking about a statewide administrative system dealing with severe mental illness that might not have been at the top of your list, but it tapped into a type of empathy that I think you bring to healthcare systems. Feels like every system I've seen you in, there's a warmth that's almost required when you interact and think about patients and their families. Well, Dr. John Oldham, I realize I haven't asked you about parenting, and boy, I bet you have great parenting tips, and I haven't even gotten to all of my angst-ridden career questions for myself, but everyone listening, I want to thank you on behalf of everyone who hears this in the future for helping us think about our personalities with incredible compassion, and that we have one, and that we should tend to it. We should get to know it better. We should have more empathy for our deficits and challenges, and we should approach our life in a way that we have a personality. We should be probably proud of some aspects of it that we're not, and in more, let's say, a loving growth mindset for parts of ourselves where we have some challenges.
Well, thank you, Drew, and thanks for inviting me to join you. I'm glad you're doing these podcasts. I think they're very informative and also uh, really interesting for people to learn in a variety of areas of importance, all with the goal of really understanding ourselves and being able to um, achieve and accomplish the best in ourselves.
Well, usually I ask everyone for a directive, but I think I'm gonna give the therapist homework, the prescription today, which is I think everybody should go take the self portrait 25, the personality self portrait that Dr. Oldham has on his website. That's really, as you hear, been crafted over. There's a 25th anniversary edition, so really thoughtful questions about who you are and then seeing where you rank, not as a way of judging yourself, but as a way of better understanding and better assessing yourself. I've not taken this, so I'm going to go do it. I'm not sure I'll be as bold as John to post my results on my website, but it's such a treat to get to speak a little bit with you. I hope we'll get an opportunity to have you back on. Everyone, please share this podcast with anybody who's curious about character or personality or struggling with a personality disorder or someone who has a personality disorder. I hope this advice finds you and helps you. And as always, may you have great next steps in your mental fitness journey and taking care of your personal mental health. I'm Dr. Drew Ramsey. Thanks so much for your time, and I look forward to seeing you in the next episode. Thanks so much.